Today's expert is Dr. Raphael Schneider, he is a neurologist that specializes in the care of people with MS and has an interest in identifying biomarkers to improve clinical care. He sees patients at the Barlow MS Center, and his research lab is at the Keenan Research Center for Biomedical Science in Toronto. He is a collaborator for both the Canadian prospective cohort study to understand progression in MS and the radiologically isolated syndrome cohort study. Welcome, Dr. Schneider.
For having me and having me talk about disease activity and progression, which really is something that I'm interested in on the clinical side, of course, because most questions that I'm getting from patients are around disease activity and progression, and also on the research side. That's my research focus, essentially. So let's begin. First of all, I want to start with some definitions and kind of take you into the clinic, or what may go through the head of your neurologist when they see you in the clinic. Now, addressing myself to a person living with MS. And I want to start with the concept of no evidence of disease activity, because this is what we're trying to achieve, of course. Now, what does this stand for? We call it NEDA, and we call it NEDA 3 as its very basic definition, where we're looking at three things only, and that would be: have there been any relapses? Has the patient experienced any clinical attacks since we've last seen them? Or very recently, if we see the person in the emergency department. The second one is a little bit trickier because it's no disability progression. So here, of course, there's different ways of looking at it, but oftentimes that will be done via the EDSS score, which we'll get to in a minute. And then the third one is the MRI activity. So as probably all of you know, we're doing a lot of MRIs, and a lot of you are getting MRIs, or your loved ones are, and people are there looking into what's happening in terms of new lesions. So stable usually means good. No new lesions or no enlarging lesions. And the idea is that people are achieving NEDA. That should be the goal, although that's not always realistic or achievable. So before I talk more about the EDSS and use this abbreviation, I wanted to just introduce you to this score. Many of you may have heard about this already. When people have a low score, that basically means it's good. So here you see depicted a little person playing tennis. So not much in terms of symptoms or complaints, with a person who has an EDSS score of 0. With low scores, people may have disability. Maybe that comes out when there is a certain stress or disability that they may be telling the neurologist about, and it's not immediately obvious on the exam. And then as the score goes up, a lot of it is weighed on mobility. So for example, a score of 6 would be a score where a person has to use a cane to be mobile. And I'm using this because when we're drawing out graphs in terms of time and disability, we oftentimes see these bumps. And what those really are, when we're drawing these, are increases in the EDSS score that a person may experience during a relapse. And of course, many individuals early in the disease will have experienced a relapse, and that for most individuals who come to medical attention is going to be that first experience of neurological disability. And many times there's going to be dramatic improvement. And then it's possible that people will experience subsequent relapses, although fortunately with modern therapies, we're able to suppress a lot of this, what's called relapse activity in a lot of our patients. Now, another concept that I want to introduce now, and really that's building on this idea of the relapses and the remission, is that to push the envelope a little bit, people have been looking into what's called progression independent of relapse activity, meaning what's happening between the relapses, or also what's happening when there is a transition to a more progressive state. So PIRA refers to disability worsening MS that occurs without any preceding or concurrent relapse, describes a gradual accumulation of disability that is not linked to overt inflammatory relapses, and reflects a neurodegenerative process rather than inflammation. And so here depicted, you again see this concept of time on the x-axis and the EDSS score, which goes up because of disability during the relapses. And in between, you have the line that describes the PIRA event, meaning that there is a certain element of progression. Now, a person may not experience this, or may experience it, or may actually say, I'm not quite sure whether or not I'm experiencing it. So that's the tricky part about PIRA. Now, let's talk a little bit about the biology that is underlying disease activity and also progression. So early in MS, we talk a lot about the lesions, the focal lesions that are seen on the MRI, that we believe are primarily mediated by immune cells that are coming from the blood, that are crossing the blood-brain barrier, getting into the brain, and are responsible for these white spots that you see on an MRI scan. And the goal really is to not have more of these, of course. Now, what is the biological correlate of progression? On the one hand side, it is impairment of remyelination of those areas, those focal areas of inflammation, because when people ask, well, what happens to those old spots? Are they ever going to go away? Well, on the MRI, usually when you do another MRI scan, you will see the old spots again, because the damage is only partially repaired by the brain, to the point that there remains some damage to the myelin, which is the insulation of the nerves. And so you would see an old lesion on a new scan in the vast majority of cases. Now, on the biological level, when we talk about progression, we talk about inflammation that may not be related to those lesions only, but that may actually be sitting in the meninges around the brain, or that may be ongoing on a microscopic level and not very obvious on an MRI scan, because cells of the central nervous system, like microglial cells, may be active around lesions. And those are more likely then to be related to progression. Some of you who do a lot of reading about MS may have heard about the paramagnetic rim lesion. That's a different type of lesion that is not always going to be overlapping with the white matter lesions that people see on MRI. The paramagnetic rim lesions are fewer, but those would be lesions where we think that the microglia are causing damage that is more likely related to progression. And we do have a harder time imaging those types of lesions, but we're getting around to including those. Now here, this is a relatively busy slide, but basically here I want to make the point that there's a lot of things that influence MS, of course. On the left-hand side, you see, for example, the biological sex, you see genetics, you see things like the microbiome that we should probably dedicate a whole other session on, including other things like comorbidities. So those are all big topics that really extend beyond what we can talk about today. But we believe that those are all important and are influencing the inflammation and the neurodegeneration that is going on, and ultimately, of course, also the patient experience. And on the one hand side, if you look at the very bottom there, you see that there's also repair that is happening. And we believe that over time, as it is the case, unfortunately, for all of us when it comes to general health, that with aging, we're struggling a little bit more to repair, whether that is wound healing or any other type of repair that the body is supposed to do. So aging can then also influence progression. Now, many of you, of course, have heard about relapsing disease and progressive disease, and when a person is diagnosed with multiple sclerosis, usually there's a certain label that is given to the person, which has its advantages because it gives access to certain medications. On the other hand, it seems to be a little bit artificial. People experience it as being artificial, and on the research end as well, we're finding it a little artificial. So I wanted to talk about that a little bit. Whether relapsing and progressive disease are really two completely distinct phenomena. And you've heard about the PIRA already, where you've got the sense that we're not really distinguishing that much between those two forms anymore. And the new diagnostic criteria that came out just a few weeks ago are actually also mentioning that there's a significant overlap between the what's previously been described as forms or types of MS. So the McDonald criteria are there to diagnose MS, ideally as early as possible. With the introduction of MRIs many years ago now, we're able to see lesions, which are an important part of getting to a diagnosis. Some people with MS need spinal fluid analysis for clarification of the diagnosis, so that is included in the criteria. And the criteria have been revised several times, and most recently in 2024, published then in 2025. And the way that they are being developed, it's basically a group of experts that are also involved in clinical trials. They have multiple meetings over a couple of years, and then 56 experts for this iteration came together, neurologists, radiologists, immunologists, and also patient advocacy participants. And then consensus was reached on certain statements, and the consensus on the statements there needed to be at least 80% agreement. So this is how we're getting to these criteria. And what was important this time around is that the relapsing and the progressive forms are more unified, and this I thought was very timely when we're thinking about disease activity and disease progression, where now we're seeing that we're unifying these definitions. And that you can see already in the diagnostic criteria. What is going to happen when a person presents for the first time to the MS clinic is that the neurologist is going to think, well, which parts of the brain are affected by what is going on, and depending on the different regions, somebody is going to then make a diagnosis, and that is going to be pretty much the same for relapsing MS compared to progressive MS now. So now what we're really moving towards is a continuum. So the relapsing and the progressive features can coexist. We're seeing this, and so the graphs are being updated. You see down there again a graph with the relapses and the remissions, but all those forms are becoming a little bit intermingled, and we're probably going to say that a person has multiple sclerosis, and are then going to be a little bit more descriptive about what their experience is with relapses and progression, see what is predominant, and what that means then in terms of the management, in terms of the prognosis, and the overall approach. Another aspect when we're talking about activity is how to monitor MS disease activity. And this is really where my research passion comes in, because I'm always imagining myself in the MS clinic. I don't have to imagine myself to be there because I'm there every Tuesday all day. But even when I'm not there, I'm thinking about the clinical situation that I'm in with a patient. So you've heard about NIDA very early in this presentation, where we're talking about the relapses, we're thinking about the clinical progression and the MRI. And if there's not much in terms of relapses and not much in terms of progression that we're seeing on the exam or hearing from the patient, we're turning our attention to the MRI. But really, there's probably room for more to better understand disease activity and progression. And this is where the fluid biomarkers come in. So fluid that can be on the one hand side spinal fluid, but what's obviously more convenient and we could test for more frequently would be something in the blood. So this is similar to other types of blood tests, like somebody with diabetes would get their blood sugar checked. The idea is to develop tests where a person with MS can also get their disease activity or progression checked, basically in the blood. So this is just another image of the MRI that we're of course seeing. So, but what about the fluid biomarkers? So there we're going back to what I showed you earlier about the disease and the biology of the disease. So we know, of course, that there is demyelination going on. That's at the center of these white matter lesions. We also know that there is a certain extent of neuronal damage that is happening within the lesion, sometimes outside, but quite a bit within those lesions. And one of the proteins that is being released there is neurofilament, which is a protein that comes from nerves directly. We also know that other cells play a role. I briefly mentioned the microglia cells, but there's another cell type called astrocytes that plays a role. And the astrocyte cell has a lot of the protein called GFAP. And these two proteins that I mentioned are going to become important later. So these cells, when damaged, can release those proteins. And again, some of you who are reading a lot about multiple sclerosis may well have heard about that we can test NFL now in people with multiple sclerosis. By the way, also in other diseases of the nervous system, this is becoming more and more popular. And just yesterday, we had a meeting with a number of neurologists and biochemists across the country of how to make NFL testing available in every clinic. And the idea here really is to try to understand disease activity and progression. You can see on the left, when you compare NFL levels in healthy controls compared to relapsing MS or progressive MS, that there's an increase with relapsing MS and a further increase in what's been called progressive MS. And there's also a correlation, again, with the disability score, which I introduced earlier, the EDSS score. So the higher the disability, the more NFL. Now, this is a little bit of a complicated slide if you're not used to looking at scientific slides, but basically what's happening here, once again, on the x-axis we have time, and you see a separation between that green curve and the blue curve. The green curve are individuals with high NFL levels at baseline, and the increase of the green curve here means that there is more progression in these individuals. So when people are having high levels when they are being tested for the first time, the likelihood that they're going to experience progression over the following years is increased. This is a slide to illustrate that NFL levels can actually be suppressed by therapy. So the yellow line here would be our most modern therapies. Also, the dark blue line are modern therapies, while the light blue line are the earlier generation therapies, and the red line would be no treatment. So meaning, again, over a period of time, here measured in years, you would see that there is a relatively rapid decrease in the neurofilament back to that zero, which is basically a normal level when people are on high efficacy therapy. And that obviously supports this idea that if people are receiving disease-modifying therapy, that would protect their brains, which is something that we see on the follow-up MRIs when we tell people that there's less new lesions, for example, or no new lesions, but you can also see it with this blood test. Another one is the GFAP. So this is the one that's coming from the astrocytes. You see in the upper panels GFAP in the serum correlating with the EDSS score again, so higher levels of disability correlate with higher levels of GFAP. And you also see below here that those experiencing progressive MS on the left have the highest level of GFAP. What we have done at the Barlow MS Center, we have compared NFL and GFAP levels with MRI lesions. And we didn't see much correlation with our typical white matter lesions. But when we're looking at black holes, which are lesions that are a little bit more destructive, we actually see, and this is in the right lower quarter, that there is a correlation with the GFAP and these lesions. And on the next slide, I want to draw your attention to the PRL lesions, the pyramidal rim lesions, the ones with the microglia around them. There's also a correlation with the GFAP. So for us, this means that the GFAP may actually tell us about a biology that is probably a little bit more destructive. So in addition to NFL, we would soon like to start using GFAP as an additional monitoring tool when it comes to progression in multiple sclerosis. And we actually believe that the NFL could be a bit more helpful in trying to understand relapses, relapse biology, and what has traditionally been called disease activity. And GFAP may be the one biomarker that tells us more about disease progression. So again, here to summarize, NFL likely more reflecting acute relapses, even though you did see these correlations with the EDSS in the future, and GFAP, a stronger correlation with progression. Likely we'll be able to use both together. Another thing that I wanted to mention when we're talking about disease activity and progression is, again, going a little bit further into what else is on the horizon. I am quite excited that we're now using NFL in the clinic, and that I hope we'll soon be using GFAP, but there's actually more. So in rheumatological diseases, people are very much focusing on proteins in the blood that are related to the inflammatory processes, to the activation of the immune system in the blood. And what we're doing in the lab, and we've showed this at the recent ACTRIMS meeting, is we're trying to identify additional markers in the blood to see if we can understand disease activity even better, so that we can increase the types of tests that we can do in the clinic, ideally having multiple blood tests that will then help us understand different aspects of the disease. So these are in red are just a few examples of what's called cytokines that are increased in relapsing MS. And you see, for example, in progressive MS, we're seeing less cytokines increased. Again, progressive MS, we believe that things are happening a bit more in the brain rather than in the peripheral blood. So this actually makes sense with what is known about progressive versus relapsing MS. But we do see some interesting candidates there as well. And our favorite that we're going to study a bit further is IL-6 or interleukin-6. So I'm really looking forward to having a discussion with you about any of these topics. I hope I was able to introduce you to some new concepts, and we can for sure talk about any aspect of what I've been talking about tonight. Again, what I wanted to make sure that comes across is that while MS was traditionally classified into relapsing and progressive types, it really is changing now, and the idea is that it really doesn't make a lot of sense to put people in the box of relapsing disease or progressive disease. It helps in certain ways when we're looking at research, for example, like I just showed you a couple of slides ago, that when there's more relapses happening in an individual, there is a different biology. We do see, for example, more cytokines. When people have more progressive disease, then we don't see as many changes in the peripheral blood anymore. So in a way that makes sense. Again, it has been useful also when you think about clinical trials. When pharmaceutical companies have run clinical trials and have been able to say, okay, let's focus on relapses and relapsing disease, and we put people in this one box, and then another trial was on progressive disease, we put people in the other box. So there has been value to doing this, and the definitions are probably still going to be used to a certain extent, also because it can be quite a different experience, of course, if somebody does present with primary progressive multiple sclerosis and doesn't know what we're talking about when we say relapses all the time. So I think there's value to these definitions to a certain extent, but at the same time, we believe that it also has significant downsides to pretend that things are very different between individuals with MS. In the end of the day, we are seeing lesions on the MRI scan, and the radiologist would not be able to tell you if a person has progressive MS or relapsing MS, because the MRIs can look quite similar. So that's not possible. The other thing is, when we're thinking about spinal fluid analysis, for example, that's not going to help us distinguish relapsing from progressive MS. And overall, we're also seeing that when people are classified as relapsing MS but are experiencing progressive disease, that's quite common, and it has been a little bit confusing because the question then is, well, what is secondary progression? Should it be called secondary progression the first time somebody experiences any features of progressive disease? So this is why these are the many reasons why people are really keeping an open mind about the idea of an MS continuum that starts with a somewhat pre-symptomatic phase. You may have heard about the prodrome, for example, or the radiologically isolated syndrome, where people have no symptoms yet. And then we have the relapsing disease and a secondary progressive disease. So that is going to be mainly unified over the next years. Another aspect that I wanted to tell you about was the NIDA, and that NIDA should be the goal, no evidence of disease activity. This was also my way of kind of describing to you what goes through the head of a neurologist when people are coming to the MS clinic and are having questions about disease activity and about progression, and why we're asking about relapses, why we're asking about what's been going on in terms of symptoms, why we're then also usually looking at an MRI scan, and why we're doing the neurological exam. So these are really three core features that are making up NIDA, and at the same time, it gives still some room now to use blood biomarkers to better understand disease activity and progression, as I've shown. I've mentioned before, and I want to say it again, I believe that combining these biomarkers is going to be very helpful in understanding MS again, and that will probably help us understand what type of activity we're seeing, if a person is likely to have progression. So in the medical field, that's what we call helping with stratification. And so I believe that there's a lot of room. We wouldn't be the first ones to do this. I mentioned the rheumatologists before and the endocrinologists. We feel that we have a little bit of catching up to do there, but we see a lot of potential. But ongoing research is needed. I told you a little bit about IL-6. There's other biomarkers in the pipeline, and the idea is to integrate those in routine practice. Again, the neurofilament we're hoping to make available across the country through collaboration, and we also believe that the GFAP is following soon, and other markers are currently under investigation. So I'm happy to take any questions. I'm happy to start with those that have been submitted previously, but I'll keep it open and happy to take any questions from the audience.
Thank you so much, Dr. Schneider, for the informative presentation. As I mentioned earlier, I live with MS, so disease progression I'm very well aware of. And it was interesting to see the expanded disability status scale, because I hear it all the time what my score is using mobility aids being 7. So thank you so much for sharing a visual of that. Before we get into the Q&A portion of our broadcast, I just want to say thank you to our viewers for your patience as we work through technical issues at the beginning of our broadcast. And I'd like to share that this webinar about MS disease activity and progression has been recorded and will be available on our website in approximately 5 business days. So, Dr. Schneider, I do have a few questions for you from our audience. So the first one here, so how might aging affect MS and the progression of possible disability?
Mm-hmm. Yeah, this is a very important question. I believe when we're focusing on getting the disease under control as early as we can. When people really feel that between the relapses they're experiencing essentially full recovery, if we're able to get the disease under control, then it is likely that the effects of aging are not going to be very dramatic. I oftentimes say that if we're focusing on prevention and trying to optimize everything we can in the MS clinic in individuals when we see them young, then the likelihood that age is going to significantly impact them is decreased. But what I do see in some individuals, and especially those who have accumulated a lot of lesions over time, is that later in life, maybe in their 60s or 70s, that they feel that they're slowing down faster than their peers. And this can be related to mobility and cognition. And so this is why I think we need to do our best when we think we can prevent disease activity and progression as early as possible.
For sure. And that's what's motivating, right? There's still a lot of work and research and more information to be shared with the community so we can start practicing some of the things that have been found.
Yeah.
So another question here is, what do you recommend as the top 2 non-medication complementary wellness strategies for people with MS to achieve better health outcomes and quality of life?
Yes. It is going to be exercise and diet that I'll recommend. Exercise, oftentimes people ask me what the evidence is, and we are running a study together with Sick Kids that is funded by the National MS Society to understand the effects of exercise on MS a bit better. But what we already gather from literature so far is that it's much better to exercise than not to exercise. Probably good to exercise several times a year, several times a week, which is what I recommend to my patients. Do something that you're able to maintain and just focus on not hurting yourself. Sometimes people with multiple sclerosis, they're asking, well, if I exercise a lot, is that going to be bad for me or for my MS? And usually the answer to that is no. You just have to be reasonable like everybody else, make sure you're not hurting yourself, and listen to the feedback that your body is giving you after you're done exercising. If you feel completely exhausted after exercise, you probably overdid it, but your body will basically tell you. And so those are some recommendations about exercise. And again, the exercise that you're able to maintain is probably the best one. So there's a bit of evidence that aerobic type exercise, like the type on a treadmill or on a bike, is particularly beneficial. But there's also been some benefits with other types of exercises that you could do in a gym, things like weightlifting. Then in terms of the diet, really trying to eat healthy. There's an official Canada Food Guide on that. We kind of know that we're eating too much processed food and too much meat, and so changing the diet to what's generally considered a healthy diet with a lot of fruit and vegetables. Some studies have shown what's called a Mediterranean diet to be beneficial, and I think those would be my 2 top recommendations. And they're also oftentimes the recommendations a person would get from the family doctor just to maintain general health.
No, that's awesome and great advice, and something that I did when I was first diagnosed. And exercise and nutrition definitely helped more than just my mobility. It was the mental health aspect of it too.
Right.
So next question I have, can disease activity and progression be different in men with MS?
Yeah, that's an interesting question. We know from epidemiological studies for a long time that men are slightly higher. The likelihood of a male with MS is slightly higher when it comes to develop progressive disease compared to a woman. Now, does that really affect the individual? I think that it is interesting epidemiological data, but if you think about the individual in the in the MS clinic, I follow a lot of men who have relapsing disease, who don't experience much in terms of progression. And I also follow a lot of women who are experiencing progressive disease. So there's probably something to be said about hormones and how they affect multiple sclerosis. We know that actually. We know it a bit more about women because we know that during pregnancy, the likelihood of experiencing a relapse is decreased. Then after pregnancy, after delivery, hormones change again, and the likelihood of experiencing a relapse increases. So clearly hormones have an impact on multiple sclerosis. But how to advise men around this and around progression is a little bit unclear. For example, thinking about hormonal therapy for men, we really don't have a lot of evidence around that topic. But maybe over the next years, there's certainly ongoing studies. Maybe we'll learn more about hormones in men and how being male affects progression.
Mm-hmm. Thank you. How does the healthcare team know when it is no longer beneficial to take an MS disease modifying therapy?
Mm-hmm. There's been a couple of trials that got recently published where basically the study participants either continued their disease-modifying therapy or stopped their disease-modifying therapy. And we also at our center are basically looking at what the data shows because, of course, some people choose to go off disease-modifying therapy at a certain time. It's really difficult to say on the individual level. At the same time, if you look at data from clinical trials, so these are studies that are done with that are very thorough, and look at who is having relapses. You see, even in young individuals, say during their 30s, that a person in their early 30s is more likely to have a relapse in the following year than a person in their late 30s. And this trend continues over the years. So then the question really becomes when people are reaching their 50s and maybe more importantly their 60s, whether or not these disease-modifying therapies are still helpful. Now, this is, of course, a bit tricky to go from what we know about groups and statistics and all that to the individual, because we are occasionally seeing a person, even in their 70s, having a relapse. And so I guess that the risk of disease activity is never zero at any point in time, but we are increasingly advising people in their 60s to consider whether or not they want to continue disease-modifying therapy. And there's ongoing studies about understanding the risk. For example, some of these biomarkers may be helpful. A person may choose to not continue disease-modifying therapy after the age of 60 or 65, and then maybe in addition to doing monitoring MRI, we may choose to use these blood biomarkers to try to understand the risk. So there's a lot of research in this field, and we'll see what we'll know over the upcoming years.
Yes, and that's the exciting part with all of the research, right? There's always something new that comes up. But no, thank you. So another question for you. Can a patient's prognosis to progressive MS be determined early now?
Yeah, that's very interesting. I think we're getting there with the tools that we're using. When we look at the MRI, if a person has very few lesions, for example, the likelihood is decreased that they're going to develop progression over the next years. However, occasionally we see an individual with primary progressive disease that just has lesions in unfortunate areas like the spinal cord, for example. So each test in isolation is probably not sufficient, but the MRI would be one to start with. And soon we'll be looking more and more into these paramagnetic rim lesions that I briefly mentioned. So if somebody has few of those, we know that is a good prognostically. Then the blood tests. So if the neurofilament is low, if the GFAP is low, that is good. So in the end, we're trying to get more and more information to get the answers to the individuals and say, okay, these are the factors that are telling me that it is relatively likely that you will experience progression, and these are the factors that are telling me that it's not. So with more tools available, we'll be able to provide better information to our patients regarding prognosis.
Yeah. Thank you. There actually is a few questions about the blood tests and the blood work. Will the new blood work greatly reduce need for MRIs? How soon will these first blood tests be available in clinics? And are the
Mm-hmm.
biomarker blood tests available at MS clinics now in Canada?
Yeah. So the first is question about the MRIs.
Mhm.
Our colleagues in Ottawa have actually made a business case around this and have been able to do the tests for several years now and get it funded that way because they've been saying, telling the hospital that they're going to use MRI less frequently. And I think even on a practical level now, on an individual level, it could help. If somebody lives far away from an MRI facility, we're trying to use this test now. Of course, what it doesn't do, it doesn't give us a complete picture. So whether or not it'll completely replace MRI, the answer is probably no. But we're trying to come up with new strategies and new protocols. For example, one could say, well, maybe I need an MRI every year, or neurologists may advise that. But in between, maybe it could be interesting to measure the neurofilament. So we're more and more trying to integrate this. There's a Canadian working group, and I'm part of this, and we have colleagues of mine across the country are, and we're trying to really understand how to best use the neurofilament. On the one hand side, because of how we want to learn how to integrate it in patient care, but it's also a question of how are we going to get the payers on board, because the test is relatively expensive. And if we're able to show that it's useful, then, well, that's number one, relevant for the clinic. Of course, we want to do a test that's useful, but that's also going to help us convince those who we would like to pay for the test, which of course shouldn't be the patients. The test is available now in many clinics, in many MS clinics. So anybody can ask their healthcare provider if the test is available in their clinic now. Not in every clinic though. But for example, in Toronto, it's available in many of the big MS clinics across the country. The test is readily available now. And additional questions about that?
I believe that was it about the blood test, just knowing the
Okay.
accessibility of it in Canada now. Thanks so
Mm-hmm.
much. I do have a couple more questions, some of them interesting. So, is the life expectancy for people with
Mm-hmm.
MS different compared to people who don't have the disease?
Mm-hmm. Well, I think the short answer to that is I would like to say no. I think it depends a little bit on how you look at the population and who you're including and which statistical methods you're using. I really believe, though, that with the modern MS care, that for the majority, vast majority of our patients, we can say that we're really focusing on quality of life, and that the quality of life is something that we want to improve. While the life expectancy, is not a primary concern because it's not significantly reduced. There's always going to be some very unfortunate individuals who have very severe disease. That is true for any disease. And of course, that is going to, if you do the statistics on that, that is going to mess up these statistics. And then the statement that life expectancy is not affected by MS is wrong. But I would say that for the vast majority of people with MS, with modern care, we're able to say that life expectancy is essentially the same, and even quality of life. We're really trying to get the message across that with modern MS care, the vast majority of our patients are able to do the things that they were planning to do in terms of university, having a family, a career. So we see a lot of that. Again, with the caveat that some people are, of course, more disabled and quickly. But we've really seen a change there over the last few years, and that is actually quite exciting, of course.
It is, yes. Thank you. So I do have one more question from a Zoom viewer. I have been told that after age 60, DMTs are no longer useful. Is this true? And do you recommend continuing DMTs after age 60?
Mm-hmm. Yeah, it's difficult to come up with a clear answer for each individual, but I sometimes think about it that way. The clinical trials that have been done by pharma companies over the years have not really included people over the age of 60. So the honest answer is probably that we don't really know that much about the DMTs over the age of 60. And a lot of the focus when these drugs came around was on younger individuals with a lot of relapses. And younger individuals, that is people in their 20s, 30s, and their 40s. And that has been oftentimes the basis of how these drugs later came to market and have justified why we're using them. And so that's one thing, right? Do we really have the answer to these questions in people in their 50s, 60s, and 70s? Probably not. But what we do know that on average, the number of new lesions, the number of relapses, again, decreases with every year, every decade, depending on how you want to conceptualize it. And the risks that are associated with these DMTs, the side effects and the adverse events, they increase. And so this is why it's wise to have a conversation around whether or not it is still indicated to stay on a DMT after the age of 60. And I just think that people have to understand the risks. On the one hand side, we talk about the risks of the side effects, but the risks of relapse activity and further disease activity from MS is not zero. So it's going to be one risk or the other, like essentially always in when it comes to medicine and healthcare. But for many individuals who have been on disease-modifying therapy for many years, it really becomes an interesting conversation to stop disease-modifying therapy after 60s. Again, just the risks have to be clearly explained.
For sure. Thank you so much. And big thank you, Dr. Schneider. This was extremely informative. We have come to the end of our time for questions. So as we wrap up today's broadcast, we want to remind you about how you can connect with the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. Connect by phone, email, or live chat through the MS Canada website. Navigators are available Monday to Friday from 8 a.m. to 8 p.m. Eastern Time and can provide assistance in both English and French. We want you to be a part of our MS community and encourage you to get involved with our programs, services, events, government relations, and volunteer opportunities. Together, we can take action to create a future free of MS. To find out how you can take action, check out our website at mscanada.ca. If you have any questions about our education activities, please reach out to the education team by email to education@mscanada.ca. On behalf of MS Canada, thank you for tuning in for today's webinar. Have a good night.